The next talk is, kind of a double talk, or quadruple talk, because only, that Professor Klaus Rabe can do something like this, because he's going to talk about small airways and vessels in diseases in asthma and COPD. So, but you only have 20 minutes, okay?
Well, who needs enemies if he has friends like this that give you titles like this? But I have to admit that when Leo gave me a call and said, listen, somebody has to talk about vasculature and about the lung, and I can think of a few people that are crazy enough to take this on, and I just thought it will be you, in this case, to do this. So thank you very much. However, I've tried to put something together for you, because I do believe that, and this is the learning experience when you prepare lectures such as this one all the time, that there are some fascinating aspects that I would like sort of to take you along with. These are my conflict of interest statements. I think it will not limit me sort of to give you a balanced presentation of this and to coming to this. If the pulmonologist, and we think about obstructive airways diseases, we are airway centric. We know about airway structure, we know about mucosal inflammation, we know about the invasion of inflammatory cells, structural cells, but we don't talk about the vasculature very much. And this is actually quite interesting. The reason for that is probably because it's very difficult to study, and the reason for that is probably that we have very little in terms of relation to pathophysiology of it, and this is something which I think is extremely challenging. This is a nice and very good review paper, and it reminds you of something which I think is something that you're probably not aware of. The human lung of the human species is one of these very own organs that has two perfusion systems. It has the pulmonary artery, which narrows down, and the terminal pulmonary arteries actually serve as the arterial supply to the distal airway, the small airway, and it has the vas privatum, it has the bronchial artery. And the bronchial arteries stem from the aorta, the subclavia, and the intercostals. Both these systems are arterial systems that both drain into a venous pool, and they drain into the same system going back to the heart. It's a unique system. No other species, no other organ actually has that. So it's very likely that something is happening in this dense mucosal vasculature plexus, and it could have a lot of, in fact, pathophysiological meanings. Now, if you look at this vasculature that you find in the mucosa, and you look at different species, sheep on the left, the rat on the right, you see there is a large species difference. It's a large and dense network, and it will actually spread below the mucosal surface, and it will form very small capillaries and capacity vessels that form actually nodules in that. And when you see on the lower right-hand side these larger capacity vessels, you understand that they have an endothelial function, and this endothelial function is actually quite interesting, because on the lower left side, after a challenge, in infection, cigarette smoke, pneumococcal infections, those endothelial cells will open their gap and they will release plasma, cellular debris, and inflammation. The lung by itself is the largest vascular bed in the human organ system. So the likelihood that this contributes to pathophysiology is actually very likely, and therefore it is even less to understand why it is so relatively unexplored, and why people haven't addressed this as a therapeutic target and in pathophysiology in a large sense. Now this is a little bit what the scenario could be. You have an airway in the upper panel, and below that you have small capillary vessels. Now these capillary vessels will have a dysfunction to some extent. They will react to an exogenous stimulus, and they will extravasate plasma, cellular material. Now this could have a crosstalk in terms of inflammation with the airway itself. It's very likely, because these cells need to go somewhere. The extravasation of fluid and cellular material, on the other hand, will, through engorgement, lead to a change in the compliance of the lung itself. So that means, since the vasculature and the endothelial cells that will actually release all these components will affect lung compliance to a large extent. And we know that from some ML experimentation that it does. And the third thing is that the vasculature as an anatomical entity may have a direct interaction, in fact, with the airway itself, and that has to do with the so-called epithelial mesenchymal unit, or the trophic unit in that, and that will and can be responsible for remodeling processes in the lung. So while we are very much focusing, when we talk about remodeling, about the remodeling of airways, it is equally feasible, very likely, that vascular remodeling occurs to the same extent, and to give you examples for asthma and for COPD, how this actually comes about. So if you look at the space, which is the space between the artery and the airway, the so-called periarterial space, you realize that within that space you have little, can we go back? You have little areas in the space, these capillaries. They are free from debris, and this all looks fine. You can see this in larger magnification, that you have the bronchial and the vascular space, and here you have this space that is free from inflammation. Upon challenge, you realize that leukocytes migrate into these capillaries. You get edema formation around the vasculature, and you have migration of inflammatory cells into the endothelial cushion of these capillaries. This occurs extremely rapidly in an animal. Now, if you look at the fate of these leukocytes, and you look at all the small capillaries, you see that these leukocytes will actually transmigrate. They would sit under the endothelium, and they would migrate through the endothelial layer into that space, ultimately at some stage reaching a small airway. At least that's what can be conceived. In a more specific way, if you look, for example, for an eosinophil, would eosinophils do the same thing? Yes, they would. They need to come to the lungs in some way. They will not go through the lymph node. They will not be coming by any other way, by transmigrating through small capacity vessels and capillaries. And what you see here is, in fact, eosinophils that migrate from the small capillary lumen towards the endothelial layer of small arteries, and in fact, they do transmigrate to the layer of this vasculature into that space. So this occurs under conditions of control and challenge. Now, if you look at the human situation, it is actually quite interesting to realize that the vascularity in this layer behind the mucosa, under the mucosa, is enriched and enlarged in inflammatory conditions. We know this from asthma, and we know this from COPD. Species differences. Sheep and dog have a very intricate and very voluminous network of that, but still, in the human airway mucosa, per square millimeter of mucosa, you can count as much as 7 vessels under normal conditions. So if you look at the relation of vascular surface versus airway surface, you realize how big this compartment in fact is, and what pathophysiological capacities you will have in that. And that's also true for COPD, although for a lesser extent. Now, what rules this remodeling process? And we know some factors that are extremely important in that. One of them is vascular endothelial growth factor. VEGF is a growth factor that will, in fact, remodel airways and will change, obviously, also vasculature in the same individual. These are relatively early data from the Netherlands from some 10 years plus ago, and it actually shows you that the expression of vascular endothelial growth factor is not restricted to the epithelium and the macrophages that we know, but also to small vasculature in the airway. So it's very likely that chronic inflammation, chronic airways disease will remodel vasculature to the very same extent. What we understand, if you look at the endothelial dysfunction, which is much more developed in cardiology and has different clusters of diseases than the lung, you see the similarities of an anatomy which is actually quite striking. These are very small endothelial sheets from capillaries below the mucosa in an animal model. And what you can see is that you have an endothelial disparity between endothelial cells staining for von Willebrand factor and CD31. So you have a plasticity of endothelial cells that are subject to actually changes of chronicity in the disease. So the vasculature is a very active component in this remodeling process. And if you look at the very right-hand side, upon challenge, you see this plasma exudation and in fact this chaotic growth of this vasculature occurring with more chronic disease, something which is very, very much likely happening to other disease states as well. If you then look at the airway and the vasculature under conditions of control on the left, under early challenge conditions in the middle and late asthmatic reactions in the right, you see that analog with the migration of inflammatory cells to an airway in the parabronchial region, you see the occurrence and the exudation in this vasculature below the mucosa. So everything that you do that would challenge, inflame, trigger a response will not only result into edema formation in the airway lumen, it will challenge and in fact stimulate the growth of vasculature and plasma exudation. And an extremely dynamic and very forceful mode, in fact, of recruiting inflammatory cells and probably changing compliance to the lung to some extent. The link between the cardiovascular system and the lung system comes from molecular biology, and this is in fact a very actual area. Triple factor 5 is a factor that's been known in cardiovascular remodeling for microvasculature. The same triple factor is now being shown in individuals with COPD to in fact being present on the upper right-hand corner. If you look at the expression of triple factor in vessels in the individuals, and in fact in airways, you realize that compared to control never smokers or control X smokers, you get the expression of this triple factor in the airways and for the same token in the vasculature of given individuals. So that means that while we understand and have always been focusing on fibrosis, regeneration, remodeling of airways, the same process occurs in parallel through the same mechanism, through the same mediators in the vascular system as well. Strangely enough, we have completely ignored that this vascular remodeling will probably change the disease as well. So I would put to you, while the cardiologists have forgotten to some extent for 20 years ago microvasculature in the heart, we still have to discover what the microvasculature and the small vessel disease in the lung actually means, because so far we have no concept of what the functional consequences are. What we do know, for example, that triple factor 5 left upper corner is made by fibroblasts. It's fibroblasts in the lung that have the propensity to make these growth factors. And these growth factors will in fact orchestrate not only parabronchial fibrosis, but also endothelial change and vascular remodeling. So why is it that we have so little insight into this? And why is it so badly studied? Well, the question is that we would have found it very difficult to visualize. Now, these are new data now coming from COPD trials and COPD data, and what will actually sort of forward us is imaging of the lung. These are gadolinium-enhanced CT scans that look, in fact, at the microvasculature and the perfusion in human lung in COPD. And what you realize is something which is very interesting, that through looking at the microvasculature between controls and even mild COPD in the upper right-hand corner, you see a rarefication of vessels in disease states. Now you would say, well, it's very obvious because COPD will have a rarefication of the lung tissue and the lung tissue will result into smaller beds of vasculature. Wrong. Microvasculature attachments and microvasculature loss occurs also in areas that are not emphysematous. So the process of diminishing vasculature and the process of diminishing alveolar apparatus are two separate entities. And it may very well be that some of the functional loss diffusion capacity changes in individuals that have no apparent emphysema is related to the microvasculature more than anything else. An area that is completely novel, an area that is largely unexplored, and microvasculature of the lung, stay here, stay tuned, this will develop to some important area. One way that we have now to actually visualize this come from optical densitometry CT scanning in the airway itself. So it's Doppler optical coherence that will actually take us forward. These are segments from human airways that come from a regular ultrasound images, and by Doppler reconstructions with coherence tomography, we can now visualize vessels at the level of 1 millimeter and less. So you can actually look at the microvasculature in an airway on time and real life in individuals with disease. This is an example from an airway of 8 millimeter diameter. This is an example of an airway of something like less than 2 millimeters in diameter and the microvasculature. So in the future, we will have a real-time imaging of that, and that probably will be the tool that opens the functional assessment about microvasculature disturbances and what actually can be done. The other point is the transmigration of inflammation. And I showed this picture from Simonetta Baraldo, I think more than 10 years ago in one of those Modena meetings, and I've been to many of those. Thanks, Leo. And it is just something that we have to understand, that the recruitment of inflammation that will be recruiting inflammatory cells in contractile apparatus, connective tissue, will also expand to the vasculature. And we've known this for quite some time. One of the first data was from Dr. Penado. The same time, Marina came with the same observations that inflammatory cells, such as CD8 cells, will be sitting in the vasculature of the small vessel itself. So it's not only that you have the property of extravasation, engorgement, and stiffness of the lung, it is also the pathway to actually modulate inflammation itself, and the vasculature is inflamed with the very same inflammatory components that we see in the airway itself. The question really is it because the proximity of an airway inflamed and the vessel is such that you have a transmigration, or are these actually two different processes that work hand in hand and actually sort of influence themselves? There are some data. The data come, in this case, from severe asthma, to make the bridge again. We looked at the inflammation of the vasculature in severe asthma, in this case, in fatal asthma. We looked what happens, in fact, to inflammation in those individuals when people die from a severe asthma attack. So what you see on panel A is the normal picture. You have a bronchus and a pulmonary artery, free from inflammatory cells. If you look under B, you see the same thing in the patient with asthma. You realize that you have around the bronchus inflammatory exudate, and you have mucus plugging in the bronchus, B, but you also see around the pulmonary artery inflammatory infiltrate that you don't see under normal conditions. If you then stain for things like MBP controls and asthmatic airways, you see that is the bronchus predominantly, but also the pulmonary area, circumferentially tryptase, elastase, affected by an inflammation that is ongoing. So it is very likely that not only the connectivity between the unit of an airway with a vessel would actually link this inflammation, but it's very likely that the inflammation itself and the vessel structure itself would remodel and be target and or expression of this inflammatory reaction in the lung. Something very different from the vasculature fate in terms of proliferation and hyperproliferation, exudation, is the fact that vessels diminish. And that is probably something which is another facet of the same phenomenon. Because if you look at the CT images of people with pulmonary vascular morphology and look at the clinical implications of these individuals in this paper that came out some time ago from the COPD gene group, you realize that if you look at a lung on the left compared to the lung on the right, that the vascular properties in this individual change. That is, when you develop chronic obstructive lung disease, your vascular bed decreases. Now, the consequence of this decreasing vascularity is, in fact, rather unclear, because on the one hand side, it's microvasculature, I showed you earlier, in the periphery, and it may be that it's not only contributing to pulmonary arterial hypertension, but it will be the distributing of vessels to the structure of the lung that have physiological consequences. Or I told you also, the distribution of emphysema and vascular disparity, or the vascular fate, is not identical. So we have to understand why some vessels would actually grow, and why they would exudate, and why they would contribute to inflammation, and what is the mechanism that makes, in fact, vessels go from the lung. There is some sort of correlation between the amount of emphysema, obviously, overall, and the vascular fate. If you look on the left side, emphysema, if you look at the right-hand side, but it is very independent from small airways disease, yes or no. So we have to understand, in terms of COPD, how microvasculature and medium capacity vessels are affected by the disease itself. So the correlation between the surface area, CSA, of some vessels that are less than 5 millimeters, and in fact the attenuation score in the CT is actually quite good. On the other hand, it's not very well related to other lung function parameters, and it seems that the vascular fate and the consequences of vascular diminishing in the lung is far from understood, and we don't know what the properties are. What is, however, very interesting is the fact that it has to do with larger vascular abnormalities as well. This is a study that I like, because it in fact looked at the pulmonary artery enlargement at the pulmonary stem and the vascular fate in the periphery. And it seems that individuals that have pulmonary hypertension and have an enlarged pulmonary arterial stem have in fact rarefication of vessels in the periphery. So large arteriosclerosis and or endothelial dysfunction of large vessels obviously speaks to the rarefication of small vessels in the lung as well, also an area which is largely unexplored. So where is this going? How do we actually proceed in this field, which I think potentially is extremely interesting, pathophysiologically important, and so badly understood and not explored and not related to clinical pathophysiology? I think the area comes from what we call the epithelial mesenchymal transition in the lung. And that is that we understood for the vascular, for the airway redistribution and the remodeling, that there is a direct talk between the epithelial cells, obviously, and the mesenchymal or epithelial phenotypes of the basal epithelial cells. And there are factors that have to do with matrix deposition and have to do with growth of the surrounding tissue. What you see in this review that has been written 2 years ago, which is state-of-the-art, vasculature doesn't occur in it. It's very interesting, isn't it? It is very pulmocentric and very airway-centric. Vasculature is not for the pulmonologist, it seems. If you look at this one, which is very interesting, and I recommend you to read this. It's from a little obscure journal, but I think it's a very, very good review. These people addressed the talk of the mucosal surface and the vasculature by a model which is called, in our words, Church-Strauss syndrome, because that's where the most of the knowledge comes. And they developed a scheme how, in fact, the epithelium with and together with the capillary bed that is not addressed in this thorax article will, in fact, be leading to angiogenic growth factors and to lead to vascular remodeling, which I think is a very interesting concept and something that can be further developed. So basically what we have to understand is what makes these cells grow and what makes these cells diminish and decrease in the lung, which I think is an absolutely fascinating thought, because it will be the source of inflammation being in the airway, and it will be the source of growth factors in the lung in the first place. It seems that if you cryo-injure human lung and you try to understand how lung regrowths, we do have quite a good idea how a re-alveolization occurs. And we have quite a good idea how the growth of bronchi occurs. But we also realize and have to realize that in cryo-injury, there is a stem cell function to regrowth vasculature. And this vascular regrowth is something that we have to understand. So what we have in terms of lung generation mechanisms and remodeling of the lung, we have now for the airway on the lumen of the trachea and the bronchus, the bronchial lumen and the alveolus, a very, very good concept what the stem cell population is that will actually regenerate the lung. Funny enough is the basal epithelial cell that has the propensity to regenerate a lot of these lung cells. It is very, very likely that in the regrowth program of the capillaries of the mucosa, you also have the same stem cell propensity that will actually regrow the lung. So it's a yin and yang. You don't want to have too many vascles because it will inflame you. And endothelial leak will lead to the recruitment of inflammatory cells. On the other hand, you don't want to have too little vessels in that because you need this for the homeostasis of this. And the generation of microvasculature and the generation of inflammation and the loss of vasculature is something that needs to be understood in the end. So this folk art from the 19th century from Mexico knew it all. That you have not only the lung that is colorful, but you also have a vasculature which is probably sort of full of surprises. And it's probably something that is really worth exploring. So while this is a very difficult topic and probably something that you haven't heard a lot about, especially in the disease of asthma COPD, I think what it's unraveling now is that we need to have a biology and pathophysiological understanding of that, because potentially this is very important and potentially it will be the key to address completely novel targets for anti-inflammatory drug and homeostasis of the lung that we don't have so far. Thank you very much for your kind attention.
Thank you very much, Klaus. Are there any comments or questions?
I would actually like to ask both of you, Manolo and in the light of this lecture, you know, when we think about small airway disease, and based on the evidence beautifully reviewed, thank you, Klaus, for the effort that you made, whether or not we should consider, in light of this review, that we should talk about micropathology of airway and vessel as potential structural abnormalities responsible for functional and clinical manifestation of disease. And I say disease because you address both asthma and COPD.
Well, I would very much agree with you. This review article that I cited and brought with me, I thought I won't read it because I don't read that journal, but when I read it, I thought it was very good. And what they tried to do is, it was actually quite fascinating. They started with Church-Strauss and said the only thing that we know is about inflammation, vascular inflammation and lungs somehow. And the argument has been, it's very interesting, they said some injury to the lung, for example, H1N1, the picture of the last epidemic started in the vasculature. So the pathology starts very much as an endothelial lesion, and from an endothelial lesion you become then an ARDS-like picture pathologically and clinically. So they said, listen, it doesn't always have to be that this is a deliver streak of inflammation to the lung, to the airway. It probably has two different components that may run in parallel or may have a life of their own. Therefore, the argument would be that since this is, I think the vasculature is the real silent zone of the lung, because nobody knows anything about this, really, in the microvasculature. The surface area and the potential of regulating homeostasis and compliance of the lung, plus growth factors, everything through that microvasculature is huge. And I think we have to understand whether, for example, and I find this absolutely amazing, that in COPD there's good evidence that you can lose vascularity without losing lung tissue. So we would always think in COPD and emphysema that would be something which is a consequence of the other. So the lung has a double life, and the vasculature is something that is underrepresented, and I think we need to go there, because I really think we don't understand it properly, and reading this old stuff is just fun. And I loved your lecture, because I really think that you came from underscoring microvasculature and came later to that. We have 10 years to go. And in 10 years, we probably also have 4 clusters about sort of what the pathology of the lung would relate to in the small vasculature in that. Filippo, yes. I'm sorry.
Well,
I think that, excuse me.
Well, we have an advantage in cardiology. We can measure microvascular dysfunction very easily with echostrace or acetylcholine. This is a big advantage. Your lecture is fascinating, and really there's a lot to do in this area. What comes first, microvascular dysfunction or lung dysfunction? This is obviously the key question. I think that we already have some clues that microvascular dysfunction can be primary. If I well remember, but I don't know this literature very well, but there are some meta-analyses showing that statins improve COPD mortality in patients with COPD, and also they improve asthma. And statins are likely to work on airways, are more likely to work on endothelial dysfunction and microcirculation. What do you think about?
Well, the statin story is a little ambiguous because the retrospective analyses were better than the prospective trials, although there are some methodological issues about the trial, in fact. But I take your argument, and I think this is absolutely right. This is why I'm saying that for some reason, the pulmonary community has not been very vasculocentric, and I don't know why. It's a fact. We came late to pulmonary arterial hypertension, by the way. Now we come late to the microvasculature. I do believe it is a potential therapeutic target, yes, but you have to close the gap between a nice pathophysiological concept and good anatomy and the functional consequences of that. And therefore, the imaging technology that is the optical tomography that we have now is the first time that we actually visualize in vivo vascular flow, vascular size, and vascular engorgement. So, but this will take off like this. There's the first trials now ongoing, and I'm thinking that will be interesting also for target development. But we are at the beginning. It's infancy for targeting it.
Very fascinating. Very fascinating lecture.
I wanted to just answer your question about the microcirculation and so on. Yeah, you know, the only thing we know a little bit about that is the the recent work by Hogg, in which they look at the micro CT scan in order to see how the small airways disappear, even before they have emphysema, according to him. And I suppose that the same thing is happening to the, since the small airways and the vessels are coupled, seguramente, probably they disappear together if they were going to disappear. But I think that the main thing is that what you mentioned before is that we've been so concerned about asthma and COPD and airways and parenchyma that we have not paid much attention, really, about the vessels, because it's, in a way, out of our reach. We cannot study, we don't know how to study them.